Good day. First of all, let me thank the organizers for inviting me to give a keynote at the 32nd Annual ISEE, albeit in a virtual online format. So today I'm going to be speaking on school closure for COVID-19 control. Now, you can see from here that there are really sort of two opposing philosophies. One is to close schools or suspend schools or not to restart schools in September for the Northern Hemisphere. And the second, in the bottom panel, you can see that there is this cartoon about school reopening and a wall of parents and teachers in opposition. So, is that herd impunity? Or is it herd mentality? So, what I'd like to first is to review some of the works that have already been published on this issue. So very recently, just 10 days ago, Myra Levinson, Mark Lipsitch have published a piece together on reopening primary schools. So they focused on primary schools only in this piece during the pandemic. And they looked at a lot of the epidemiological evidence and importantly, also looked at the pedagogical reasons of opening or closing schools. And really, they concluded in the most profound way, and here I quote, "Whether and how to reopen primary schools is not just a scientific and technocratic question. It's also an emotional and moral one. Our sense of responsibility towards children, at the very least to protect them from the vicissitudes of life, including the poor decision-making of adults who allow deadly infections to spiral out of control, is core to our humanity." So, if you look at the World Bank Group, the education division, they actually, in this model that you see in the bottom half of the slide, it's a simulation looking at the potential impacts of COVID-19 school closures on schooling and learning outcomes. And they simulated it for different countries in the world. I'm not going to belabor the details on this slide. You are welcome to go and look it up online, but I will show you the key results here. So this paper that the World Bank Education Group put out presents findings of the simulated exercise considering different lengths of school closures in terms of 3 months, 5 months, or 7 months, and different levels of mitigation effectiveness, mostly remote learning, of course, by Zoom or by WebEx or any other online platform, resulting in an optimistic, as you can see here, each of these figures has got an optimistic, an intermediate, and a pessimistic scenario in addition to the baseline. Now, they actually simulated it using data on 157 countries, and they find that both the global level of schooling as well as learning will fall, not unexpectedly, if you decide to suspend schools. And COVID-19 could result in a loss of between 0.3 to 0.9 years of schooling adjusted for quality, bringing down the effective years of basic schooling that students achieve during the lifetime from 7.9 years, as you can see here in Figure 7, to between 7 to 7.6 years. And close to 7 million students from primary up to secondary education could drop out due to the income shock of the pandemic alone. Now, and if you actually look at the other three figures, without compensatory actions, when children return to schools, school students from the current cohort could on average face a reduction, and here is the expected earnings graph, could face a reduction of 355, optimistically, 872, the intermediate line, or up to $1,400 in yearly earnings, depending on the scenario. And in present value terms, this amounts to between $6,400 to $26,000 in lost earnings over a typical student's lifetime. And as closures continue in low and middle income countries, the pessimistic scenario is probably more likely. Exclusion and inequality will likely be exacerbated over and above these average figures. Now, globally, a school shutdown of 5 months could generate learning losses that have a present value of 10 trillion. And by this measure, the world could stand to lose as much as 16% of the investments that governments make in this cohort of students' basic education. And therefore, it is so important that we consider school closure very seriously. And if you look at figure 9 and figure 10, they show you average PISA scores falling 16 points or 4% in the intermediate scenario, from a baseline of 440 down to 424. And the share of students below the PISA level 2 will increase by 10 percentage points, or 25% in the intermediate scenario, assuming that the distribution actually skews. So very serious pedagogical and learning outcomes consequences. So now, looking now at this very recent study by Olga and colleagues published in JAMA, again, just a couple of weeks ago, it's basically an interrupted time series negative binomial model. And what it does is it looks at time from school closure on the horizontal axis in both panels, and then daily COVID-19 incidents on the upper panel and deaths in the lower panel per 100,000 population. And of course, these are segregated by quartiles, as in the bottom 25th, the next 25th, then from the 51st to the 75th, and then the top 25%. And then looking at all states which actually close schools between March the 13th to March the 23rd in the US, there are unfortunately no positive or negative controls because all 50 states actually closed schools during this 10-day period. And the adjustment of co-varying non-pharmaceutical interventions was likely insufficient. And therefore, the correlation between school closure and other NPIs reflecting the state's approach generally were not looked at or accounted for. And if you actually look in this model where they define a lag and then they look at the end of the lag period, and basically, of course, it very nicely shows that by the end of the lag period, you see this plateauing of incidents and then plateauing and then subsequently dropping off of deaths. But the 62% incidence and 58% mortality reduction are really implausibly high compared to pandemic and seasonal flu that we have experienced in the last 2 decades. And I will show you that slide subsequently. So, this is another study which was published again recently based on the South Korean experience. It was published in EID a few weeks ago, and Park and colleagues really very admirably put together a very large contact tracing database. And what it shows is by age group, in household or non-household settings, what is the proportion of positive tests, that is, positive infections, out of all the contacts traced. And what they showed was there was hardly any difference between the different age groups. And certainly, if you look at school-age children, so upper primary and all through the secondary years, this seems to be quite high, which is unlike many of the previous studies showing a much lower susceptibility amongst this age group. So here you see things being fairly flat in non-household settings as well. But again, because this is a very large contact tracing database, it is unclear what the direction of infection was. Was it from kids to adults or vice versa? So again, it was unclear. So let me just share with you some new data that we've just put together. It is currently under review, and it is based on two very large case and contact databases, which is really the entire case and contact databases from Shenzhen in Guangdong province in the south of China, and from Anqing in Anhui province, which of course also had this complete case contact database. And what we were able to do was to, for each and every single entry, we were able to piece together clusters. So infection clusters, whether they are household or non-household, when they got infected, when they showed symptoms, when they might have passed it on, and of course some of these are intervals, not precise dates, because infection events are not observable, but can only be inferred. And then when they were placed under quarantine. So these were the two databases we were able to work together with the Shenzhen and Anjing authorities to put together. And what we were able to do then was to analyze within household transmission of COVID-19 in these two places. And the line lists and the outbreak investigation records that allowed us to do this, I've just shown you. And here is a very, very busy diagram. There are 6 panels, so just let me go through each of them one by one. So figures A and B, all right? They show you the age distribution of household contacts and primary cases, okay? So primary cases here in this panel, panel B, and then contacts in this panel, in panel A. And then for the contacts, we also show you those who are infected, again desegregated by age. We then develop a transmission model to simulate the spread of COVID-19 within households and estimated, all right, in this age stratified household transmission model, we were able to then look at the relative susceptibility by age groups. And we estimated that children were less susceptible to infection than adults. And specifically, if you look at this diagram, individuals age 0 to 12, that is primary school age and below, so here and below, and those who are high school and university age, 13 to 23, all right, were 0.43 and 0.51 times as susceptible to infection as those age 30 or above. All right? So, of course, we assume that there was uniform susceptibility above age 30 based on our prior of a systematic review of the published empirical evidence. Now, so if you now then look at this panel, it goes to relative infectiousness, okay? So we inferred that young people under the age of 23, they were all relatively less susceptible by about 1/2. But there doesn't seem to be an appreciable or significant effect if you look at infectiousness. And this is largely because we have got very few actual infections caused by primary cases who were younger than 20. There were actually only 15 of them. And they were co-primary cases with their parents or caregivers. That's actually here, okay? And so that's why you can't really make a huge amount of inference here, and the credible intervals are quite large. So if you then go and then look at the bottom 2 panels, then from this, we also worked out the incubation period, the generation time, and the serial interval. And of course, if you actually look at the incubation period and the serial interval, and look at the distribution and the overlapping distribution by the chronology down here in the horizontal axis, you can also infer that 58% of infections occurred before the infectors developed symptoms, which is very similar to a previous piece of work that we did, He et al. In Nature Medicine, based on another database in Guangzhou, in Guangdong province, where we estimated 44% to be the pre-symptomatic transmission proportion, which is again not dissimilar to the 35% estimate by Christoph Fraser's group published in Science earlier on during this pandemic. And finally, you can see that we have also, through that same household model, infer relative transmissibility after the Wuhan lockdown, very effective. Transmissibility in Anqing relative to Shenzhen, which is about the same. Relative susceptibility of men versus women, same. And relative infectiousness of men, which is actually double that of female. So, now, what we did was to extend another previous age-structured model we used to estimate clinical severity, i.e. CFR and IFR of COVID-19, to simulate the impact of school closure on transmission dynamics on COVID-19 and influenza for 152 jurisdictions. And here I just want to show you what we did was to actually use synthetic contact matrices, all right, that were derived from the original European Polymod project. That was empirical work, and it was a diary-based method, and it was done for a number of European countries. And based on this, and making some relatively appropriate and reasonable assumptions, then these were then used to construct synthetic contact matrices for 157 countries, and in fact it was upgraded to 172 countries in the most recent version, Prem-et-al., which is a preprint that was just uploaded, I think, again, about 10 days ago. So what we did was really to then look at all 152 countries or jurisdictions, and if you look at the different colors, they denote low and lower middle income countries, high middle income countries, and high income countries. And this really shows you three things, okay, in the three panels. It shows you, number one, reduction in the R0, two, control threshold on the R0, and three, percentage reduction of infectious contacts in workplace and community. So the top panel first. Each of these panels actually also has, this is pan flu back in 2009. This is COVID-19, and there you have no age effect on susceptibility. So what you can see is the relative reduction in R0 conferred by school closure was primarily driven by the proportion of contacts made in school, which is, of course, the horizontal axis. You can see that this really gives you the reduction in the R0. Because school children were more than twice as susceptible to the pan flu in 2009 compared to adults, school closure could generally reduce the R0 of pan flu 09 by 20 to 50%, okay, as you can see here. And so this contrasts with what you see with COVID-19, because we've just shown you in the previous slide that actually, if you go back to the previous slide, relative susceptibility is only about half in children, not twice. And therefore, this accounts for the major difference between pan flu and COVID-19. And this is instead the pattern that you see in terms of reduction in R0 if you actually close schools. Now, if you then go down to this panel, all right, and that is, if you just close schools, what would have to be the reproductive number so that you could actually drive it down below 1 with just school closure alone? And here again, you would probably need to see 1.5, it could be up to 1.5 or even 1.6, somewhere around this 1.4 to 1.6. If it's pan flu, because of the relative susceptibility of children being twice as likely, if you close schools, you could still drive that R0 to below 1, okay? But actually, if it is COVID-19, you would need your baseline R0 preschool closure to be very close, especially if you're in a high-income place, to be very close to 1, maybe 1.1, 1.2 here, in order that closing schools could actually drive it down. So you would actually only be able to affect so much only when you are very close to that threshold already. And then, of course, if you look at the percentage reduction of infectious contacts in the workplace and community, and that is, what does that mean? That is, what is the similar reduction in R0 that can be conferred by school closure that could be equivalently achieved by reducing infectious contacts at work or in the general community? So here is basically what COVID-19 shows you, such that really, you know what? Closing schools can give you maybe 10 up to 20% in sort of mid and high level income countries, and maybe a bit more in lower income countries. And compare this to the impossible situation where it would have to be almost 100% reduction in order to actually compensate for school closure. So this is, of course, much more easily achievable by actually just doing work from home arrangements, if you can, as opposed to even if you work from home, you can never replicate the equivalent of school closure. Now, here is another figure where we show the public health impact in terms of reduction of peak prevalence for all ages, okay, which is here overall, or age 18 or below, school-age children, or older folks. And here, it's the absolute reduction, the relative reduction, and that's really what we're looking at. And then if you actually look at the different colors, then you will see, again, different income level countries. And then if you actually look at the triangle, circle, and the cross, it assumes different baseline R0s. That is, what is your baseline reproductive number as and when you actually consider school closure itself. So for COVID-19, the reduction in morbidity and mortality conferred by school closure would depend on the baseline R0. As you can see here, very different. These three are actually three very different R0s, and they don't actually cluster together unless you reach here, or actually when you are in here, these places. But essentially, the baseline R0 actually makes a huge difference. If the baseline R0 was around 2.5, which means that your outbreak is largely unmitigated, implementing school closure throughout the epidemic would reduce peak prevalence in high-income and other populations by roughly around 15% and about 25% respectively. That's really looking at this panel 3A. And then the reductions would be slightly higher for school children, right? You can see here in this age group, all right, because they are the target group of school closure, and lower for older adults. Well, because physical interactions between children and the elderly are relatively weak in general, everywhere. But in contrast, if your baseline R0 were around 1.5 only, that is, your school closure is only used as a complementary measure in addition to other physical distancing measures, okay, then implementing school closure throughout the epidemic would reduce peak prevalence by a slightly higher amount, all right? And therefore, the reduction in final infection attack rate, or the IAR, okay, would be lower than that of peak prevalence. So this is IAR and this is peak prevalence. So this slide shows you a comparative table of the reduction in the reproductive number for pandemic flu 2009 and seasonal flu during school closure and holidays. So we applied our model really to make sure that we actually get at least some validity from the published estimates. So as you can see, comparing across, most of our estimates come very close actually to the published estimates, and these were all empirical estimates, so it gives us added confidence that our model is actually valid. And of course, you can see that these actually are observed in the UK, in Hong Kong, in India, in mainland China, in France, in South Korea, all over the world. So they give you some extra confidence that our model, as I've described, actually works. And of course, going back to my earlier comment about the Auger et al. Paper in JAMA, they estimated school closure to actually reduce incidence and mortality by around 60%. And if you actually look at these estimates, that's why I suspected that that particular JAMA paper might have actually yielded in that negative binomial model implausibly high reduction estimates. Now, here is a set of cartoons from the New York Times. So the conclusion of our study is not that school closure should or shouldn't be done, but it needs to be put into context. And if it is done, then you could realize what we estimated to be the proportion reductions in terms of the overall R0 and then the clinical burden. But if you do not wish to go for school closures, but instead would like to restart schools, say in September for the Northern Hemisphere, then the following tips from the New York Times may be very useful. So it's not just actually at school, but also on the way to school. You need to enforce strict social distancing on the buses. And as they wait to get into the school and get the temperature taken and the symptom diaries logged. And of course, many schools would try to keep students in pods so that if indeed there is one or two students who may get sick or confirmed with COVID, then you would need to actually close down the whole school again, but rather just focus on the close contacts within these pods. And then, of course, you can repurpose larger spaces like gyms and cafeterias so that you can have much sparser seating arrangements and so that students are physically distanced. Now, for teenagers in high school, they are at slightly higher risk compared to primary school age children, as our model also showed, and therefore physical distancing will be even more important, and therefore shields at their desks and getting rid of common shared facilities like water fountains or even lockers, and making sure that they do good, proper hand hygiene would be very important. Here is my team. So Joe Wu and Kathy Leung were primarily responsible with our Shenzhen and Anqing colleagues on the school closure work, and Eric, Ben, and Wu Peng had been absolutely instrumental in some of our other COVID-19 work right from the very beginning in January. Here are our funders, both locally as well as overseas. Thank you very much indeed.